But let's go ahead and start recording this. So. Yeah, I think we will go ahead and get started with our webinar today. We've already got a good number of people on, and let me see here if I can. I'm going to minimize my little screen there so everybody hopefully can see the full screen. And definitely feel free to either unmute yourself if you have a question during the webinar. We'll certainly allow time for questions towards the end. And/or type your question into the chat box, and we will do our best to address those. As always, slides and maybe pertinent documents or attachments and the recording will be sent out to everyone after the webinar. So our topic today, a little bit of a different topic, exclusive breastfeeding and maternal substance abuse will be the majority of our subject today. And then a little bit towards the end about some of our new training options at the Oklahoma Breastfeeding Resource Center. So why this topic? I think as we get in and see some data from our Oklahoma Healthcare Authority about the challenges that we're facing with particularly opioid use. And we've been getting more questions and emails from those of you, around the state asking about, well, what about breastfeeding in these kinds of situations? So we thought this would be a timely topic. It certainly impacts step 6 of our baby-friendly 10 steps in trying to keep moms and babies exclusively breastfeeding. So I'm certainly not an expert on substance abuse. I'm not a social worker. And here's, hopefully, let's see, is my slide going to advance here? Of course, we have no financial interest. All of our work with Becoming Baby Friendly in Oklahoma is funded with a contract through our Oklahoma State Department of Health. But yeah, further disclosure, as I was saying, I'm not a social worker. I'm not an expert in maternal substance abuse, but have done my best to kind of review all the current guidelines and recommendations and compile that for you so we at least know how this topic impacts our efforts to support breastfeeding with our families. So our objectives today, to describe the current data on maternal substance abuse in Oklahoma, current recommendations for exclusive breastfeeding, and many of you are going to be familiar with that, but we'll just do a quick recap on that. Then we're going to review the Academy of Breastfeeding Medicine's protocol on the drug-dependent woman, so I've pulled out a few key pieces of that. Current recommendations for treatment of the mother while she is breastfeeding. And then the last couple of objectives to look at our new program, BSEP, Breastfeeding and Continuing Education Program, and clarify the difference between that and our current 15-hour online training. So a few slides at the end on that topic. This is really truly an epidemic now, both in Oklahoma and around the country, as many of you are aware, and that opioid use and the deaths related to opioid overdose has just skyrocketed. And in fact, 85% of prescription drug-related overdose deaths involve opioids. And in Oklahoma, those overdose deaths occur more than deaths due to meth, heroin, and cocaine combined. So, and some of this is information from our recent publication from the Governor's Initiative on Reducing Prescription Drug Abuse in Oklahoma. So a little bit of more information from that, that the amount of prescription painkillers prescribed and sold in the U.S. has quadrupled in recent years, and in actually a fairly short period of time. And yet, interestingly enough, there hasn't been an overall change in the amount of pain that Americans report. So we're getting these heavy narcotics, and yet the amount of pain that we actually report has not changed. So that's interesting. And sadly, Oklahoma is one of the leading states in the sales of prescription painkillers, and I thought this statistic was just appalling. For every 100 people in the state, there are 128 painkiller prescriptions, and that was in 2012. So, so that means a certain segment of our population is getting huge numbers of these prescriptions. And as we look at, I don't know if this is going to, does this show up on your screen?
I have to look.
Yeah, so I'm going to move this in case that blocks for y'all. This is also from the governor's report, just so you can see the death rates in Oklahoma in recent years. And what's a couple of things that are significant about this chart, and this is deaths per 100,000. So, for example, when you look at the yellow bars are male and the black bars are female. So we have 20 deaths per 100,000 in males in the age range of 25 to 34, so our young adults. And that in general, if you look at where the largest numbers are, or the highest rates are, it's in our older, particularly our older middle-aged populations. But still, if you look at childbearing age women, the 25 to 34 and the 35 to 44, we still have some pretty significant death rates in those populations as well. So absolutely a concern there. Now, this next set of slides, I want to give full credit to Dr. Michael Herndon, who's the Chief Medical Officer with the Oklahoma Healthcare Authority, and he gave a presentation recently for the at our perinatal quality improvement leadership team, and allowed me to use some of his slides. So this will be some data on Sooner Care members. So these are going to be our pregnant women enrolled in Sooner Care in Oklahoma. And this is from fiscal year 2016, so July of 2015 through June of 2016. And in that time period, we had 30,000 of our, roughly 50,000 births per year that were born to Sooner Care members, and almost 4,000 members that had opioid prescriptions filled up to 3 days before delivery. And you can see here how they broke it down by trimester. And so, for example, in the first trimester, close to 1,500 Sooner Care members, pregnant women, who filled almost 2,400 prescriptions for opioids. And then those numbers certainly increase in the second and third trimester. So just to kind of give you an idea of the picture there. Out of those unique members, close to 4,000, you can see members that just maybe had one prescription, all the way to, we have a significant number of pregnant women who were filing 6 to 10 prescriptions, 11 to 15, and then even a handful of members that filed more than 21 prescriptions during their pregnancy for opioids. The most common opioids, hydrocodone, far outranks all of the others, but codeine and oxycodone are some of the next most commonly prescribed. So we know that. Now, Dr. Herndon also cited some data from a recent study by ACOG, and looking at Medicaid women who had completed their pregnancies, delivered their babies, almost all of the states. And in that article, almost 22% of those women filled at least one opioid prescription during pregnancy. So even around the country, we're seeing certainly very high rates. They cited an increase during some of the study period of 18% to almost 23%. And also, similar to Oklahoma, codeine and hydrocodone were the majority of prescriptions. And South and Midwest had some of the highest rates there. The most frequent pain conditions that prescriptions were filled or given for pregnant women, no surprise to many of us, abdominal pain, lower back pain, headache syndromes, joint pain, migraine, and so forth. Now, of course, when we treat a pregnant woman, then we have the impact on the baby. And I know this is what y'all are seeing in your facilities, is certainly the increase in neonatal abstinence syndrome. So this is just, once again, looking at Sooner Care members, but this is, 2/3 or more of our babies in the state. And just to give you a quick visual of how much this has increased from 2008 to 2016, maybe 2 babies per 1,000 born had NAS, and now we're up to 12 or more per 1,000. So huge, huge increase. And as you look at this another way, just to see the numbers, so in 2008, 2 babies per 1,000, and we're actually really almost up to 13 per 1,000. So 6 to 7-fold increase in babies being born with NAS. Now, the healthcare authority is not sitting idly by and watching. Of course, they have a pain management program. They have a toolkit. They do cover substance use disorder treatment. They want to make referrals for substance use disorder treatment, and they've brought in, have a state plan to involve providers, prescribers, to provide education and try to develop guidelines, and also working with the pharmacies to look at limits, on numbers of prescription or numbers of pills and so forth. So definitely hard at work to try to address this epidemic, but the recommended treatment for a woman with opioid use disorder during her pregnancy is medication-assisted treatment, or MAT, and they recommend use of methadone or buprenorphine, and both of those drugs are considered safe and effective during pregnancy. And this is much preferred to encouraging the woman to just stop or try to wean off of opioids and not provide her some other treatment at the same time, or having her just continue illicit drug use. So just in the short time that they've been implementing this, they've seen certainly some decrease. So just so that you can see, the green bar are the third trimester opioid prescription. So look at that, decreasing from 2,800 to 1,800 in just a couple of years. So, but still very, very high numbers. So you have a good picture of that. All right, well, let's then look at how this is going to impact breastfeeding and the work that y'all are doing in your hospitals, trying to send as many moms and babies home fully or exclusively breastfeeding. So many of you are familiar with the AAP's current recommendation of exclusive breastfeeding for about 6 months, continued breastfeeding, adding in age-appropriate complementary foods, and continuing breastfeeding for a year or longer. And the AAP also says hospital routines should be based on the 10 steps to successful breastfeeding. So following those baby-friendly guidelines. So that brings us to step 6, of course, which is the exclusive breastfeeding. Exclusive breast milk feeding shall be the feeding method expected from birth to discharge, when we kind of get into the details of step 6. And that baby-friendly hospitals, once you become designated as a baby-friendly hospital, then the data that you send into Baby-Friendly USA each year should show some reduction in routine supplementation or supplementation of the breastfed babies that was not medically indicated. So those are some of the guidance from Baby-Friendly USA. We also have family physicians, American Academy of Family Physicians, that also strongly supports and encourages exclusive breastfeeding. And I really like their quote, "Respect the decision of the mother who chooses to breastfeed exclusively by not offering formula water or pacifiers unless there is a specific physician order." And in their main breastfeeding policy, of course, they talk about They just comment on, supplementation, can be done with expressed mom's milk, pasteurized donor milk, or infant formula. So back to the AAP's policy statement on breastfeeding and the use of human milk, their most recent one, which is 2012, and I kind of need to check my sources out there to see. I'm sure they're working on a revision because they try to update that or revise it about every 5 years. So this is 2017. I'll have to look into that. Anyway, just reminders, of course, make sure babies are feeding frequently, that we're doing a thorough evaluation of breastfeeding during the hospital stay, and that we are not giving any supplements unless medically indicated, and using standard evidence-based guidelines. In this instance, for the management of hyperbilirubinemia and hypoglycemia, but that would also include situations such as, what about the mother who's has a substance use disorder, which is what we'll get into. Of course, the Joint Commission, exclusive breast milk feeding is the newborn receiving only breast milk, and nothing else. Donor breast milk, of course, is allowable. So just quick review on that, which brings us then to what about the mother who's admitted to your service and has a history of substance abuse during pregnancy, or maybe she's even undergoing methadone treatment during her pregnancy. So we're going to look at some of the guidance that's in the Academy of Breastfeeding Medicine, their most recent revision of their clinical protocol number 21, which is guidelines for breastfeeding and substance use or substance use disorder. And so when we send you the slides, this has the hyperlink, but I'll also have a reference slide towards the end as well. And for those of you who aren't familiar with the Academy of Breastfeeding Medicine, it is a physician organization similar to AAP, ACOG, though it is an international organization, and it's multidisciplinary. So any physician that has strong interest or practice, some type of clinical connection to breastfeeding can join that organization, because of course that's their focus. So they have family medicine physicians, pediatricians, obstetricians, infectious disease, and internal medicine, a wide variety of medical specialties that can belong to this organization. And any of their clinical protocols, which are fabulous documents if you haven't checked any of those out, they are all produced with funding from our federal government, from the Maternal Child Health Bureau. So, and they're all posted online, and they do try to update them once again every 5 to 6 years. So this is a recent revision of this particular protocol. Anyway, pulling a quote from that, drugs of any type should be avoided, ideally, in pregnant and breastfeeding women. But we know that's not that's not always possible, and most women during pregnancy or breastfeeding are going to take some type of medication. But we hope it's prescribed certainly for specific medical conditions. And just here's an example of a pamphlet from our SAMHSA, Substance Abuse and Mental Health Services Administration, so the federal agency, kind of like CDC and so forth. But they have a lot of information about methadone treatment for pregnant women. And as I said, we shouldn't be giving any medications unless they're prescribed for specific medical conditions. So that would bring us to the question of, well, if a woman is undergoing medication-assisted treatment for her opioid use disorder, is that safe during lactation? So the first thing I wanted to address is that very question. So pulling data from the most recent edition of Medications in Mother's Milk, and this would be replicated to some degree on LactMed, which is the federal website as well. But as you can see, methadone and buprenorphine are the most commonly prescribed drugs recommended for this MAT. and they're both L2, lactation risk category 2, so very low risk or considered safe or compatible with breastfeeding. For methadone, only small amounts pass into breast milk, even when the mother's taking fairly high doses. We know that neonatal abstinence syndrome occurs in breastfeeding infants after delivery, whether the mother's being treated or not. And a fairly recent study showed that when these babies are breastfed, that it actually reduces their incidence of NAS to a significant degree, so almost cuts it in half. And then buprenorphine is L2, and the doses received by the baby are actually clinically insignificant. You can see the relative infant dose is, maybe 0.1 to less than 2%. In general, anything less than 10% for relative infant dose is considered safe during lactation. Now, there is a newer transdermal patch that may be out there that's in use to some degree, but we don't have any data on that. And then there can be a combination with prescription of buprenorphine and naloxone. And then naloxone, we already know buprenorphine is compatible, and naloxone is actually a very poor oral absorption, so that's even adding that in is not going to be an issue. And in fact, the plasma levels in the mother were undetectable 2 hours after an oral dose. So, so certainly the medications themselves are not an issue. So back to ABM's protocol, and so a few key points from here that some other factors to consider is that substance use disorders in the mother frequently mean that there are other behaviors or conditions occurring that can also be risky for the breastfed infant. She might be using other drugs. She might be at risk for other infections such as HIV or hepatitis B or C. Psychiatric disorders certainly are more common with substance abusers. She might be using tobacco, and we certainly know the risk to the baby of tobacco use during pregnancy, and then and even afterwards with increased risk of sudden infant death syndrome and so forth in the home environment. So ultimately, they said drug-exposed infants who are already at high risk for a lot of other issues stand to benefit significantly from breastfeeding. So that was the key point. Now, some of the challenges that we can encounter, while they have good data on babies who were exposed during pregnancy and following those babies after pregnancy, including breastfeeding babies, we don't really have any data on babies who potentially, who, for example, may not have been exposed during pregnancy, but the mother started abusing during lactation. So, but given what they know with babies who were exposed during pregnancy, you would think that that would be potentially even less exposure if they were only exposed postpartum. So, another challenge, of course, is that substance abuse treatment, particularly for pregnant women, is often not available. So definitely that's a challenge. And they keep changing the terms. Is this maternal drug use, maternal drug abuse, maternal substance use disorder? I saw a number of different terms, so that causes some confusion as well. But the most critical challenge that they cited in the ABM protocol was just the research to give us, to help develop enough evidence-based guidelines in treating both the mother and the baby. So other challenges, of course, on the clinical side of things, that the vast majority of babies born to women who are getting the MAT or the methadone treatment during pregnancy are going to experience neonatal abstinence syndrome. And that can lead to breastfeeding challenges, as many of you have probably encountered. That babies with NAS are going to have increased difficulty with latching on, sustaining the latch, sucking, swallowing, sucking rhythmically, and so forth. And just as a group, the mothers on methadone maintenance are less likely to choose to breastfeed. Now, I would question how much were they encouraged to consider breastfeeding. They may have been actively discouraged by some of their healthcare providers or family members who assume that that is not something safe to do. So the ABM protocol goes on to say that women on stable doses of methadone maintenance should be absolutely encouraged to breastfeed, regardless of the dose that they're taking. That there is a reduced severity and then a shortened duration of treatment for the baby when the mother's on methadone breastfeed. And that when you look specifically at the mothers taking buprenorphine, that those babies also had less severe NAS and were less likely to require some other, medicine or pharmacological intervention than the formula-fed babies. So breastfeeding does have positive impact on the babies in these cases. Just bringing in, a few other organizations, and so that we can see that the recommendations are all pretty consistent with each other. This is from the American Academy of Pediatrics when they talk about breastfeeding and methadone in their policy statement, that adequately nourished narcotic-dependent mothers can be encouraged to breastfeed. Ideally, they be in a supervised methadone program, and of course have been screened for HIV and other illegal drug use. So I've included here just so you can, I was going to try to look up and see what we had available in Oklahoma, but I'd really like to kind of check in with our health department colleagues to see what programs they may have. But at the current time, you can go on SAMHSA's website and they have a locator, and you can type in a particular zip code to see where there might be some sort of treatment center in your vicinity. So there are some resources out there. So that was AAP. So we've heard from the Academy of Breastfeeding Medicine. We've heard from the pediatricians. And now ACOG just last month, hot off the press, came out with their committee opinions set number 711 on opioid use in pregnancy, use disorder in pregnancy. They refer to it also as opioid agonist pharmacotherapy. That's quite the tongue twister, which is medication-assisted treatment. And of course, their recommendation, consistent with the others, is that the mother should be on methadone or buprenorphine, and that she should also be getting counseling and behavioral therapy for that. So, and I've got the link to that publication on this slide. So, and some of the reasons that from our OBGYN colleagues is that MAT can prevent withdrawal symptoms in the mother, prevent complications of non-medical opioid use. It can improve the mother's adherence to prenatal care. She's going to come to more prenatal visits, more likely to continue her prenatal care, more likely to continue her addiction treatment, and ultimately it's going to reduce the OB complications at delivery. So, but they say all of this knowing that medication-assisted treatment during pregnancy does for sure lead to expected NAS in the infant, but that is treatable. And it's much more important to get this treatment started during pregnancy. So they do go on to specifically address breastfeeding and say that breastfeeding should be encouraged in women who are stable on their methadone or buprenorphine, not using other drugs, and of course, don't have HIV, which would be considered a contraindication. So lastly, kind of from these different organizations, and this is also hot off the press from the Council on Patient Safety in Women's Health Care. They just came out with a whole toolkit, patient safety bundle on OB care for women with opioid use disorder. And just pulling a couple of quotes from the end, incorporate family planning, breastfeeding, pain management, infant care counseling, other resources for, care throughout the perinatal period, and in particular provide breastfeeding and lactation support for all postpartum women on pharmacotherapy. So all of these organizations are in consensus on treating this and encouraging breastfeeding at the same time. Here in Oklahoma, and that, you know, and when you look at a recommendation like this, kind of what the mental health and substance disorder providers, you know, would describe as wraparound care, providing all those aspects of care. And in Oklahoma, our state health department has what they call the Oklahoma Systems of Care, so they're working on trying to provide those wraparound services, particularly for families with children or youth that might be impacted by substance use disorder or mental health issues. So it could be, you know, the youth themselves, or it could be, you know, the parent or something. So we know there's something out there. Anyway, so that was, as I said, kind of a, hopefully just a handy overview and to put all of those recommendations in one place for you. These are most of the references. I have one other reference I just came across that we will include, and it's actually from a nursing journal on clinical management of the breastfeeding mother-infant diet in recovery from opioid dependence. So it goes into a little more specifics, but so it could be another handy document for you. So I am going to pause for just a second and see, are there any questions on any of that information so far before we switch gears and talk about staff training? And if anybody does have a question, you can type in the chat box or unmute yourself. And may think of something later on too. So let me minimize this again. All right. So part B, talking about an old yet new program, fondly known as BSEP around Oklahoma, I think. Breastfeeding, a continuing education program for healthcare providers. So many of y'all are familiar with this and have actually utilized this program in the past. And so for those of you that might not be familiar with it, it is a comprehensive self-paced, so key on self-paced program for really any healthcare provider that's working in maternal child health. So certainly appropriate for physicians, you know, nurses working in many different clinical settings, dietitians, WIC peer counselors, WIC nutritionists, lactation consultants, social workers, you know, others that may have a good percentage of their patient population that are in the pregnant, postpartum, and breastfeeding period. So the original owners was an organization known as Rising Star Education, actually, privately owned by Judy Harris and Linda Miller, who were longtime OBGYN nurses here at the Health Science Center, and who helped manage and oversee the Oklahoma's state program for PSEP, the perinatal continuing education program. And as some of you will know, that after 20 plus years of managing that program and helping oversee that program statewide and visiting many of your facilities and getting lots of questions about breastfeeding, that they developed this course, almost like a fifth book to the 4-book PSEP program. They did get approval from the Centers for Disease Control to really model this exactly after PSEP, so it's the same concept. And then, they've administered that program for, probably 15 years, and have been talking about retiring for some time, and or finally making that happen. And anyway, so to kind of get back to what BSEP is, it does address all of the required elements for baby-friendly hospital staff training, and that includes the skills verification. So I see a comment from Karen, which I'll get to here in just a second. So it includes 15 modules in the book itself that cover the didactic education component. So it does really meet all of the bullet points of that 15 didactic hours of education. And it also includes the skills competencies that Baby Friendly requires. So overall, if an individual healthcare provider completes this program, they will receive 22 contact hours. It is approved for contact hours for nursing staff. We are looking into whether we can apply or should apply for continuing education credits for lactation consultants. So once it's approved by an accredited provider of continuing education in any healthcare specialties such as nursing or dietetics or something, then that is that certificate of completion can be utilized for lactation consultants as well. So I hope that makes sense. Does that make sense, Pedro? So if you attend a conference and it's approved and it's a breastfeeding topic and it's approved for nursing contact hours, you can turn that certificate in or use that as verification for some of your lactation consultant requirements as well. So let me just check real quick to see what Karen is posting. Let's see. So Karen says, our pediatricians recommend no breastfeeding if the mom is positive for any drugs, including THC, marijuana. We hear that at other hospitals, including OUMC, that might not be the case. We want to be safe with our babies, but we also want all babies to get breast milk whenever possible. How is it handled at other hospitals if mom is positive for marijuana? Woo! That's the $1 million question, Karen. I will, let me circle back around to that towards the end, and we'll see if others have any comments on how they handle that in their facilities. If others of you want to share how that's handled at your facility, and we will come back to that towards the end here. So let's see. Okay, so that's back here. That's BSEP, an overview. So the BSEP curriculum is evidence-based, providing an education on what best practice is. It is multidisciplinary and a team-building approach because it's a train-the-trainer platform, which many of you are familiar with. So if your facilities, whether it's a clinic or a hospital or a wet clinic, private practice group or what have you, you would have one person on your staff that attends the Train the Trainer seminar and becomes a trainer for the program, and then the rest of the program is actually, self-study that the individual works through the books themselves. Linda Miller and Judy Harris did win an award at the National A1 Conference one year they had a research study that was published in Joggin showing significant positive change in attitudes and practice with this program, and won an award at A1 for that. But the key here is that it's a Train the Trainer platform, and so your facility, must have a trained facilitator, and they shepherd the staff through the program, kind of make sure they're staying on track and getting it completed, and then they are the ones who are trained to verify the skills competencies on site. So, and just FYI, we will be having a Train the Trainer, our first Train the Trainer seminar with a little help from Linda and Judy as we kick this off. And that will be here on campus on October 25th. It's an all-day course, that each person attending will get a trainer workbook, a binder with the information in there that they need. And there is a fee for the training, but the fee includes the full day of training, their trainer manual, and the BSEP book itself. So the trainer will be able to work through the program and receive the 22 continuing education units as well. And then, as you have a trainer on site and you want to purchase or have individual staff work through that, then you would purchase the individual book, which this is what it currently looks like. We will, of course, be working to make some changes in that over the course of the next year or so. But right now it still looks the same. And it's $100 per book for the total of the 22 contacted hours. So, all right. So what's the difference? What do I do? BSEP, or what about the OBRC's 15-hour online training? So just to clarify, we were very excited to be able to develop the online training and get that out there. So OBRC's 15-hour training, which many of you have already have staff enrolled, many of you have staff that have completed it. So that is certainly a very good option, and it meets the 15-hour didactic education required for baby friendly, but it does not have a skills component. It is approved for 15 contact hours, and the cost for that is $30 per individual if you're a hospital that's participating in becoming baby friendly in Oklahoma, and then $60 for individuals or facilities that are not participating. So the initial development of this was funded with a grant from our state health department, actually some CDC funding that came through our state health department, and then part of a grant from COBA, our Coalition of Oklahoma Breastfeeding Advocates, which helped us complete this training and really enabled us to provide as low a cost as we possibly could training to our hospitals to help you meet the staff training requirement. So the only challenge we have is that, right now there's no further funding for ongoing revisions. So we're offering this, to just barely cover the cost of maintaining this online, but we'll have no further funding to be updating the program or making revisions to it in future years. So our goal is that we will be converting the BSEP program, at least the hard copy book part, into an online program for that didactic portion. You would still have BSEP trainers on site for the skills component, and eventually we'd kind of be basically merging, some of the still current OBRC content with the BSEP program, and eventually discontinuing the OBRC training because that would go out of date here in the next couple of years. CEUs are only approved for about 3 years, so that's kind of our time frame. And then, of course, the income from BSEP will allow us to continue updating and maintaining the program. So which one is best for your facility right now? I would say if you can provide skills verification in-house, if you have qualified staff to do that, then make use of the online training. That's what we put it out there for. You will have to provide your skills training and make sure you document that and be able to provide that documentation for assessment. And as always, you can schedule one of the Making Breastfeeding user classes at no charge. That's still funded through a health department contract as well. And we cover 4 of the 5 skills verifications in that class. We don't cover the formula prep. Don't make me do formula teaching. So, Karen is saying you can't hear me. And everybody hopefully still hear me. I got way too far. And then otherwise, if you want a comprehensive program, and that helps also provide you all the necessary documentation of the training, then send 1 or 2 of your staff to a Train the Trainer seminar and purchase BSEP books for your staff. And then knowing that they will also receive the 22 contact hours as well. So, so that's really all I had to cover on that. Julie says background noise as well. Let me pull this back up here. I don't know why the audio is fading. I hope everybody can still hear me. Our last 2 slides have updates on them with upcoming trainings. We're doing NBE in Tahlequah in September, and then we'll have another one here on campus in October. And then I'm doing a 2-day breastfeeding training that will be in Tulsa on the OSU Tulsa campus. And all of those you can access on the OBRC website under training. And then to highlight or save the date for the summit in March, our 6th annual Becoming Baby Friendly in Oklahoma Summit on March 2nd. So just one more. And then just so y'all know, we have identified topics and bringing in a couple of other speakers for some of our last webinars. So in October, we'll have Barbara O'Brien and her team presenting on Baby Friendly as a Quality of Care Initiative. And then in November, we have Heather Baker, who is a licensed social worker with the OB-GYN clinic here, and talking about how social workers support breastfeeding. And then in December, I will be contacting our baby-friendly hospitals ahead of time just to get some feedback from y'all and current status and maybe current challenges, so we can just talk about life after designation and what's going on at our hospitals that are currently baby-friendly. So I'm going to go back to, let's see, Karen's question and see. I didn't see anybody else post. I know. So yeah, marijuana is going to be the big question, especially now that we've got several states that have legalized marijuana. So there are lots of questions on that. I do know that we haven't had any recent research on impact on the baby when the mother is maybe an occasional marijuana user during lactation. But Dr. Tom Hale, who publishes the Medications in Mother's Milk, has a study that he's close to publishing. So hopefully we'll see some new information come out in the next 6 months. We'll certainly be on the lookout and let you know as soon as we see that. I know that at OU, the mother comes in and she was positive for marijuana or whatever, that at least while she's in the hospital, they will let her breastfeed. It's not the transfer to the baby in that colostral period in that first couple of days, but it's what's going to happen after discharge. But certainly all of those mothers or if the baby is UBS positive, then all of those are going to be referred to the social worker who's going to look out. And that would be a good question that we can bring up with Heather on her presentation as well. What resources are out there, and how do we follow up or get those mothers into the right kind of support so that we can encourage breastfeeding and yet know that that baby's going to go home and be safe. Which I think is a concern whether she's breastfeeding or not. If she's a substance abuser, that's really the overall concern. Is that baby going to be safe? So that's where I think our social workers will definitely be of extreme importance. So let me see if I see any other. I don't see any other questions. Does anyone? Hope everybody was still able to hear me okay. Any other questions from anyone that's out there? Yeah, I have everybody unmuted, so if you had a question or wanted to say anything, you can feel free to unmute yourself too. All right. Well, I think, if anyone, any questions come up, y'all know how to get a hold of us. You can definitely email. And we did record this, so we'll be sending the slides out probably, if not tomorrow, by Monday. What is today? Wednesday?
Right.
Sorry, I just by Friday. So we'll try to get that out to you by the end of the week. So thanks to everybody for joining us today, and hopefully we'll see you in October. Bye-bye.